Greetings, I am Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I am particularly delighted to welcome you to the multimedia summary for the journal's November 2017 issue. There are 4 articles this month that have been selected as our Editor's Choice or Highlights articles. Our Editor's Choice is an original article that reviews the results of a national survey of 35,922 U.S. physicians in active practice in 2014, who were asked to comment on the likelihood of reducing clinical hours in the next 12 months and the likelihood of leaving current practice within the next 24 months. Dr. Christine Sinski and colleagues from the American Medical Association in Chicago, Illinois, and from Mayo Clinic in Rochester, Minnesota, undertook this study so as to address how burnout and other dimensions of professional satisfaction, such as satisfaction with work-life integration or the electronic health record, affect their career plans. Even after accounting for an influx of advanced practice healthcare professionals, the United States Department of Health and Human Services projects a shortfall of 45,000 to 90,000 physicians by the year 2025, as the U.S. population ages and the prevalence of chronic disease increases. The survey participants in the report by Sinski and colleagues were assembled using the American Medical Association Physician Master File, a nearly complete record of all U.S. physicians independent of American Medical Association membership. Participation was voluntary and all responses were anonymous. In aggregate, approximately 20% of 6,452 responders report that it was likely or definite that they would reduce clinical work hours in the next 12 months, and approximately 27% of the 6,496 responders indicated that it was likely or definite that they would leave their current practice within the next 2 years. On multivariate analysis, burnout and dissatisfaction with the electronic health record and work-life integration were all independent predictors of both the intent to reduce clinical work hours and the intent to leave a current position. Burnout and age were the strongest factors related to the intent to leave medicine altogether to pursue a different career in the next 24 months, with those burned out and age 50 to 59 years at particular risk. The authors conclude that if physicians follow through on these intentions, the potential for profoundly worsening projected shortfalls of U.S. physicians is quite significant. Concerted efforts are thus needed to address these issues at the national and organizational level to preserve the adequacy of the physician workforce. This article is accompanied by an editorial authored by Dr. Christine Olson from the Yale School of Medicine in New Haven, Connecticut. Dr. Olson notes that physicians' burnout is an early indicator of health system dysfunction, thereby signaling to decision makers the need for modifications that will circumvent health system failures. She suggests that by monitoring burnout, threats may be identified and addressed in a cost-effective manner before they disrupt patient care. In essence, the well-being of both individuals and systems may thereby be sustained. The fact that burnout increased across all medical specialties between 2011 and 2014, but remained stable in the general population, underscores that this is a workplace issue. Dr. Olson believes that monitoring physician well-being is especially important now that the majority of physicians are employed in large organizations and thus may lack the authority to act independently. Our first highlight article in this issue of the Proceedings is an original article which describes 25-year physical activity trajectories from young to middle age and assesses associations with the prevalence of coronary artery calcification. It is authored by Dr. Deepika Ladoo and colleagues from the Department of Physical Therapy at the University of Illinois in Chicago and numerous institutions in the United States. The authors assessed 3,175 participants in the coronary artery risk development in young adult study, the CARDIA study, who self-reported physical activity by questionnaire at 8 follow-up examinations over 25 years. The authors undertook this study largely for two reasons. First, there is a paucity of data regarding the association of physical activity and the development of subclinical atherosclerosis. And second, cross-sectional data have shown that asymptomatic patients with 2 or more metabolic risk factors who regularly engage in physical activity of 30 minutes or more 1 to 2 times per week have a lower prevalence of coronary artery calcification than those who are sedentary. 3 distinct activity trajectories were identified in this study by Dr. Ledoux et al. Below physical activity guidelines, meeting physical activity guidelines, and 3 times physical activity guidelines, designated trajectories 1, 2, and 3, respectively. In general, all 3 physical activity trajectories show an age-related decline from young adult to midlife. Notably, trajectory number 3 participants with 3 times physical activity above guidelines over 25 years as compared with trajectory 1 participants had higher odds of coronary artery calcification. Stratified by race, white participants in trajectory 3 were particularly prone to develop such coronary artery calcification. This study aligns with prior studies demonstrating a U-shaped or reverse J-shaped relationship between high doses of leisure time physical activity and cardiovascular and all-cause mortality, including, for example, the Million Women study and the Copenhagen City Heart study. Ledoux et al. Speculate on the possible mechanisms that may underlie the risk for coronary artery calcification and subclinical atherosclerosis imposed by physical activity greatly exceeding guidelines, including such mechanisms as shear stress-induced vascular injury. The authors emphasize the need for further analysis of the pathobiologic mechanisms accounting for calcification and the long-term clinical significance of such calcification in otherwise healthy, aging, highly active individuals. The second highlight article in this month's issue is a brief report that examines post-sedation neuroexcitation sometimes attributed to intravenous injection of the sedative hypnotic drug propofol. It is authored by Dr. Diego Carvalho and colleagues from the Departments of Neurology and Anesthesiology at Mayo Clinic in Rochester, Minnesota. The movements associated with these events may seem to indicate convulsive activity, but rarely have been comprehensively evaluated. The authors provide video recordings of 3 healthy patients who emerged from sedation with transient but repetitive violent motor activity and impaired consciousness. All patients received propofol and fully recovered without adverse outcomes. The authors postulated that the movements were propofol related. All 3 patients were sedated using an institutional conscious sedation protocol, which includes conscious monitoring of heart rate, respiratory rate, and pulse oximetry. Blood pressure was measured every 3 to 5 minutes, and the protocol was performed by a nurse anesthetist under the supervision of an anesthesiologist. Visual recordings from these 3 cases represent a unique illustration of the variable spectrum of manifestations of possible propofol-induced neuroexcitation. The recordings clearly distinguish propofol-induced neuroexcitation semiology from semiology of seizures because the patients in this report showed a combination of spontaneous clonus and trashing movements, quite unlike seizures. Because propofol has a prolonged terminal elimination, delayed manifestations are possible long after sedation resolves. There is, however, no evidence to support the occurrence of long-term adverse consequences after these spells. Notably, the authors found no evidence of seizures clinically or electrographically. The authors conclude that it's reasonable for clinicians to avoid sedation with propofol in subsequent procedures for patients who experience propofol-induced neuroexcitation, so as to avoid the potential risk of similar reactions. The third highlight in this month's issue is the next feature in the Symposium of Precision Medicine, which discusses pharmacogenomics, the use of genomic information to individualize drug selection and use in order to avoid adverse drug reactions and to maximize drug efficacy. It is authored by Drs. Richard Winchelbaum and Libby Wang from the Department of Molecular Pharmacology and Experimental Therapeutics at Mayo Clinic in Rochester, Minnesota. Individual variation in drug response phenotypes can range from inadequate therapeutic efficacy to serious, potentially life-threatening adverse drug reactions. Pharmacogenomic information is increasingly integrated into the electronic health record, and accordingly, pharmacogenomics will likely be broadly implemented in patient care. The authors discuss the origins, the development, the clinical implementation, and the future prospects of pharmacogenomics. The authors also provide a comprehensive table of Food and Drug Administration pharmacogenomic biomarkers for non-cancer therapeutics and a table of drug gene pairs in Mayo Clinic's pharmacogenomic electronic alerts, which are formulated to be useful for the practicing clinician. The authors underscore the progress made in the study of pharmacogenomics, and the genomics or genetic information can be effectively applied to maximize drug efficacy and to minimize adverse drug reactions. Readers who complete the appropriate documentation can receive up to 1 hour of CME credits in conjunction with this article. As always, you can access the highlights and editor's choice articles free of charge during the entire month of November. If you visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, you will find other free content such as our Path to Patient image quiz, Art at Mayo Clinic, stamp vignettes on medical science, and interesting medical images. Mayo Clinic Proceedings also offers access to our social media, which you can access by clicking the button at the top of the home page to follow us on Facebook, Twitter, and YouTube. Our website lists many news stories that are based on articles published in Mayo Clinic Proceedings. You can also check out our YouTube channel, where you will find videos of full author interviews, our 60 seconds video article summaries, and our Mayo Clinic Proceedings fireside chat recording, which is available from our website on our homepage as well as through iTunes. And as always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.